morning, everybody. First of all, I would like to thank Uday for hosting us here. And as he mentioned, we've been in touch for quite a while. And if you look from the outside, the research which has been done here by this group in this field of microbiome, bacterial overgrowth, is really stunning and has shaped the field. And therefore, I'm really delighted to be here, and I look forward to see what's happening here and also to explore what opportunities of future collaborations there are. My talk today is about functional gastrointestinal disorders. And when I was a resident, these kind of patients were considered patients who are a little bit mad, but in reality, there's nothing wrong with them. And I hope that after this presentation, most of you can walk away with a conclusion that's worthwhile to look into this field, and that this is most likely a very heterogeneous group of conditions with a biologic cause which requires treatment, because at the end of the day, the disease burden for this patient and society is significant, because in the Western world, a significant proportion of all patients we see come because of functional GI disorders. It's much more prevalent as compared to organic diseases like inflammatory bowel disease, and the patient are really affected. Okay, now let's try this. Therefore, the aims are: what defines functional GI disorders? What's the pathophysiology? And I will a little bit focus on immune activation, microbiome, brain function, and I will not talk much about motility and sensory function, which are the traditional concepts. And then the second part is how to target and treat the underlying conditions to correct the pathophysiology and what measures are available. And ultimately, maybe we can discuss what are the future developments and what directions of research. When we talk about functional gastrointestinal disorders, we have a lot of definitions, the Rome definitions, but I think a very practical is here. In the routine clinical setting, unexplained chronic or relapsing GI symptoms. And these are patients who have a broad spectrum of symptoms. These are patients who sometimes have some abnormalities like diverticulitis or diverticulosis. Some of them have a Helicobacter pylori infection. But if you're honest, these abnormalities do not explain symptoms. And this is a group of patients with so-called functional gastrointestinal disorders. And I mentioned all the definitions. Here's the Rome criteria, a lot of work which has been invested to better define and delineate these conditions. And I think the biggest benefit is that the condition, as a consequence of the Rome work, have been much more recognized, and their criteria to develop clinical trials and treatments. But I don't think, and you will hear it a little bit later, that this is the endpoint that we have reached. The purpose of the Rome criteria is that we identify a subgroup of patients with very specific symptom clusters, which then allow to be specifically targeted, and we can develop drugs that target these symptom clusters. And to be honest, I think we haven't made much progress after the introduction of the Rome criteria. If we look into contemporary trials, the gain over placebo usually is 15%. And the better, more defined the drug class is, the worse is the increase over placebo. Therefore, symptom clusters maybe are not perfect, but this is what Rome tries to achieve. Okay, and these are the different categories Rome proposes: disorders of the esophagus, gastroduodenal disorders like functional dyspepsia, bowel disorders, and anorectal disorders. 4 groups, and the groups are essentially a reflection of the working groups which the Rome Working Party has. But if you step back and reflect this patient, and these are data which Nick Talley has generated many years back, we have a considerable overlap of the different groups. Therefore, you have the patients in the population who have dyspeptic symptoms, then we have chronic constipation, we have patients with IBS-type symptoms, and reflux disease, and they overlap. And therefore, if these symptoms overlap, probably a delineation in groups is not that perfect. Therefore, considerable overlap of the different functional gastrointestinal disorders. And there's not just overlap of GI symptoms. This is a study which we did many years back, and we did combine 3 cohorts. One was population-based, The other one were patients who went to their GP for the treatment of their symptoms. And the third group were patients who were referred by a GP into a tertiary center. And what's depicted here in yellow are gastrointestinal symptoms, and blue are extraintestinal symptoms like back pain, depression, headache, joint pain, fatigue. And then there was a symptom score calculated for GI and extraintestinal symptoms. And what you can see here that, and this is for obvious reason, if you're in the population, your symptom load for GI symptoms is significantly lower as compared to patients who have been seen by a GP, and significantly lower as compared to patients who are being referred to a specialist. But in parallel to the GI symptoms, the extraintestinal symptom severity also increases. Therefore, there is not just an overlap of the different symptom clusters, the GI symptom clusters, there's also considerable overlap of gastrointestinal and extraintestinal. And if you see a patient who has severe extraintestinal symptoms in the presence of GI symptoms, it's a good predictor that this is a patient where all the diagnostic workup which you can offer will not find any pathology. Therefore, considerable overlap of extraintestinal symptoms and symptoms of functional gastrointestinal disorders. And the big problem is this patient has lots of symptoms. We have this wonderful Rome criteria, and we have very sophisticated Rome questionnaires with, 20, 30 pages of questions, and many patients are not able to complete them on their own. And therefore, during the last couple of years, we developed in Brisbane an instrument which has the name Sargent, Structured Assessment of Gastrointestinal Symptoms. It's a very simple tool, 2 pages, 22 items, and we routinely use it now for all patients. When a patient rocks up, the nurse gives them the questionnaire, and while the patient sits in the waiting room, they complete it. And we have now around about 30,000 data sets on file with the diagnosis and all the symptoms. And I think this is something which is very important to move towards standardized assessment of symptoms. We deal with patients who come because of symptoms, not because of any lab test who is abnormal, but routinely we just ask, how are we today? And we don't capture the symptom pattern properly, and these kind of tools can be helpful. And when we utilized Sargent and did a factor analysis, we had slightly different outcomes as compared to the Rome criteria. We had just symptoms of the esophagus, we had epigastric symptoms, and we had bowel disorders. Therefore, it's a much more streamlined, and we saw quite a bit of overlap in spite of the factorial analysis which pointed towards this 3-factorial structure. Therefore, the conclusion here, it's probably not fully consistent with the Rome criteria, and this is consistent with this study where Uday also played an important role by CEDA, published in Gut last year, where the conclusion was they more or less confirm the Rome criteria, but if you looked really at the factorial cluster, it was not really confirmation. Therefore, it's partly confirmation. Therefore, what I thought, well, maybe Rome is burning, and we published this a couple of weeks ago in Gut and asked the question, and not everybody likes this, whether Rome is burning again. Therefore, I think a conclusion here could be that it's very important if we deal with this patient, whether it's in the routine clinical setting or in the research environment, that we apply standardized assessment and document the symptoms. And while there was initially in Brisbane a lot of resistance to use a questionnaire, now everybody uses this. It goes automatically into our medical record. And if you see a patient repeatedly, you really can compare the symptoms a patient reported 4 weeks ago, before this treatment was started, and the symptoms which he has today. Therefore, this is quite helpful. Another thing which we did with this instrument is this little study. We recruited 1,100 patients, consecutive cases who came in the outpatient setting. They got the proper diagnostic workup. And at the end, we had 120 patients with functional dyspepsia, IBS, or an overlap of functional dyspepsia and IBS. And the question here was, what are the drivers for the overlap? And this is just a picture of our Sargent, 22 items, and at the end, hard to read, we asked, what is your most important problem? What's your second most important problem? And we asked back pain, fatigue, anxiety disorder, depression. And it's very interesting. If you ask a patient whether he's depressed or has an anxiety disorder, this is very well correlated with data from a standardized questionnaire like HETS. Therefore, a simple question, 2 items, has a good predictive value. It doesn't rule out depression, anxiety, but if somebody has a significant problem, he will tick the right box. And here's the data of the study. We categorized the patients overall into subjects who had low-intensity symptoms, then patients who had moderate-intensity symptoms, and patients who were severely affected by the disease. And the different colors here depict patients who had functional dyspepsia only, yellow, an overlap of functional dyspepsia and IBS, and the blue one are patients who have IBS only. And what's quite interesting that if you look at the low spectrum of intensity, you find a significant proportion of patients who have just IBS or functional dyspepsia, even though there's still some overlap. But the more you move towards the spectrum of severely affected patients, the majority of patients actually has an overlap. And if we reflect about the clinical trials typically, or in the past, always have requested that patients, when IBS was done, only had IBS symptoms. What this means, you shift the whole cohort into the group of low-intensity symptoms. And this will have implications for the response to therapy. If you go for the patients who have low-intensity symptoms, the likelihood that you get a minimal improvement because there's a ceiling effect is very high. Therefore, if you go for the more severe where you accept that there's overlap, most likely you have a more significant response. And we did a study in functional dyspepsia many years back, which was published in the New England Journal, and we were heavily criticized that we had a more realistic inclusion criteria. Therefore, while the patient was supposed to have as a predominant symptom functional dyspepsia, they also were allowed to have a little bit of IBS. And what we did not know at that time point, this is how you get patients who have severe symptoms. And then others tried to do a study with just functional dyspepsia. They ran into huge problems to recruit patients because if you look at this, pure functional dyspepsia is a very rare condition. Most patients have an overlap. Therefore, it's somehow artificial. You run into problems to recruit patients. And they did a study all over Europe, and it took 3 times longer than anticipated to recruit the patients because all patients with significant disease burden had overlap. Therefore, this is a problem with overlap and the impairment of quality of life. And therefore, overlap of functional GI symptoms is related to the severity of symptoms. If you avoid overlap, you will end up with patients who have low-intensity symptoms. What about other symptoms and comorbidities in these patients? And this is a systematic review from Michael Camilleri. And what you can see here is the comorbidity of anxiety, depression in functional GI patients as compared to psychiatric comorbidids in patients with organic disease. And very consistently, more than 50% of these patients do have comorbid anxiety and depression. So the question simply could be asked, is it in reality a psychiatric cohort of patients who are driven to the doctor by their psychosomatic or their psychiatric conditions? Or you could ask the question, is this hanoric? Are they depressed and anxious because they are severely affected by the symptoms? Or is there a brain disturbance that actually causes the perception of symptoms and causes gut abnormalities? And I think while I don't have a proper answer to this, a final answer, this study actually provides some insights. And in a nutshell, 50% of patients in the population who have functional GI disorders have their psychiatric abnormalities or problems prior to the onset of the functional GI condition, and the other 50% have it the other way around. Therefore, we may have patients where the brain is a driver for the symptoms, whereas in other patients we actually have the primary abnormality in the gut. And if you think about the causes like post-infectious IBS, and I don't have time to go into this, it makes perfect sense. And if you have patients with PTSD, where the psychological trauma occurs first, We see a lot of patients, lots of veterans who return from Afghanistan or Iraq, from the Australian Defence Forces, who have PTSD, and a large proportion also develops IBS. Therefore, we have a brain-driven condition and we have a GI tract-driven, where, for example, inflammation, bacterial overgrowth, and these conditions play a role. Another topic is inflammation, and how does inflammation connect to symptoms and the psychiatric comorbidities. And the inflammation in the gut, there are really stellar work, landmark studies from Marjorie Walker, from London, and Nick Talley, and you see here this cluster of eosinophils in the duodenum. The amazing thing is, if we send to our pathologists the slides, they always send us back the message, normal numbers of inflammatory cells. If we send them to Marjorie Walker, completely blinded, and ask Marjorie, can you count the eosinophils? You suddenly see a subtle difference between healthy controls and subgroups of patients with functional gastrointestinal disorders. Therefore, there is a subgroup of patients who have eosinophils or duodenitis characterized by an increase of eosinophilic cells, which are typically linked to meal-related symptoms, and therefore there is something happening, and it reminds me a little bit of Helicobacter infections, that it was always considered normal, but this is real, and we need to better study it and convince our pathologists to give us precise counts. Now back to the inflammation and psychiatric comorbidities. This is a study which we did in patients with IBS. And we took PBMCs, brought them in culture, and measured the release of pro-inflammatory cytokines. And here on the y-axis is a release of TNF-alpha. On the x-axis is the anxiety score as measured with the Hamilton Anxiety and Depression Scale. And what you can see is a very nice correlation between the release of TNF-alpha and the severity of anxiety and depression. Therefore, it's very interesting that cells which we bring into culture who are active and produce these pro-inflammatory cytokines, that this is linked to depression and anxiety. I mean, on the first glance, it's really surprising, but if you reflect about yourself, when did you have your last bad flu? If you have a bad flu, you feel fatigued, you feel crook, and this is probably exactly the same mechanism. You have a systemic inflammation, which is not very severe. It's not like a bacterial inflammation, but it's enough to activate your PBMCs, and this has influences on your brain function and your mood. And here we measure it as anxiety, but we also see that there's depression and fatigue. Therefore, the question is, are the inflammatory mediators linked to the manifestation of functional gastrointestinal disorders? And here's some data. Again, on the y-axis, TNF-alpha. On the left group, these are healthy controls, and then patients with mixed IBS, patients with constipation-dominant IBS, and patients with diarrhea-dominant IBS. And what's clear in the group with diarrhea-dominant IBS, most of them have significantly higher release of pro-inflammatory cytokines from PBMCs as compared to the healthy controls. And even in this group of mixed IBS and constipation-dominant IBS, there are patients who have this immune activation. Not all of them. And if we look at functional dyspepsia, exactly the same. Here, around about 50% are above the range of the healthy controls. Therefore, release of pro-inflammatory cytokines seems to be associated, at least, with this kind of conditions. Okay. Is there a link between the intensity of symptoms, TNF-alpha release, and pain frequency, and very close correlation? More TNF-alpha release, more episodes of symptoms. And then the next question is, where does this inflammation originate from? Is it somewhere? Is it different? And having in mind this data of immune activation, inflammation in the duodenum, we looked at the proportion of gut-homing cells. And one conclusion is gut-homing cells are increased in the patient with functional gastrointestinal disorders. But when we link this to the delay of gastric emptying, which is shown here, is that the increase of gut-homing cells is actually related to delay of gastric emptying. And if you reflect about the studies the old studies on very potent prokinetics like ABT229, which is a motiline agonist, which essentially normalizes in everybody gastric emptying. It doesn't have other neuromodulatory effects. When the studies were done, the company got really excited because they realized that there's a significant difference between active therapy and placebo. But when they looked closer at the data, the disappointment was great because the patients who were on placebo had a better outcome as compared to patients treated with a strong prokinetic. Therefore, what you do is you dump the food into the duodenum, which is sensitive, you induce more symptoms. And most likely the delay of gastric emptying is a reflection of the hypersensitivity, and this hypersensitivity is linked to the activation of the immune system. Therefore, immune activation causes increased sensitivity, and this is then related to delayed gastric emptying. And you don't win if you, in this patient, if you normalize gastric emptying by a very potent prokinetic. Here the data are anxiety and TNF-alpha, and I think we can skip this. Now, what about brain function in this? The typical cohort which has immune activation very consistently are patients with Crohn's disease. And when you see this patient in the clinical setting, in Australia, essentially everybody and his dog who has Crohn's disease now is treated with anti-TNF-alpha drugs. And most people believe they're exceptionally powerful, but what I always found striking is that patients feel very well immediately after the administration of the drug, and then after 6-8 weeks, the symptoms come back, they feel fatigued. Therefore, patients say, well, I feel great after the injection, and it's not just the abdominal symptom, diarrhea, it's more this general well-being, and then this disappears. Therefore, what we did in these patients, we measured them before and after, in randomized order, after the anti-TNF administration. And these were all patients in complete remission of their Crohn's disease. And we did a nutrient challenge. Therefore, they got our standardized test meal, 600 cc of Ensure or similar enteral feeding solution with 1.5 kilocalorie per milliliter. And in total, everybody gets 600 as long as they tolerate this. We measured the cumulated symptom response to this test meal. And these data are shown here. And we did a functional MRI in a scanner before and after. And we didn't do any balloon distension or other things. They just got some tasks to solve. And these tasks were frustrating tasks and other things. And Marcus Gray, our neuropsychologist, was responsible, and he can much better explain all the little tricks he played with the patients. But in a nutshell, if you do this, you have a change of the symptom response to the test meal. Before the anti-TNF repeat administration, the symptom response is higher, and you see this on the left side, panel A, and there is a change of attitudes towards the psychological challenges. In a nutshell, if you have received your anti-TNF-alpha, patients perceive the glass as half full. They are much more positive. Before the next dose, it's half empty. They have a much more negative processing of afferences, and you can actually measure activation in specific brain areas which are changed due to the anti-TNF-alpha administration. Therefore, anti-TNF-alpha truly changes brain function. Okay, now let's change a little bit gear and look into the gastrointestinal microbiome, which is a very hot topic at the moment, but I'm not sure whether we are there yet, either with the technology or our approaches. If we reflect about the microbiome, most people automatically think about and study stool microbiome. But I think this is only a small proportion of the story. Therefore, the stool microbiome essentially is a luminal content, and this is transient. I just saw a paper from the Mayo Clinic who said in constipated patients, the stool microbiome is stable. Therefore, you just measure stool microbiome. But it's not stable. If you change your diet, if you eat specific things, so later on the effect of traveling, your stool microbiome will change. Therefore, the stool microbiome is probably a random number which reflects what you eat. It may reflect the speed of your colonic transit and other factors. But it's important for the metabolism. It's important for the production of vitamins, and maybe some of the metabolic products actually have effects on the brain or effects on the integrity of the colonic mucosa. And then on the other side, we have the so-called mucosa-associated microbiome, or MEM. And this is a very interesting beast. When a child is born, the GI tract and the mucosa is considered to be sterile, non-colonized. And during the first 6 to 12 months of life, this mucosa is colonized by the bacteria this child is exposed to by the siblings, parents, and the environment. And there are huge differences. And in parallel with the colonization of the mucosa, the immune system develops and learns to tolerate these bacteria. After the first 12 months, the immune system cannot learn it, and therefore by that time point, the microbiome is something like standard, or not standardized, it's defined, it's like a fingerprint of this dividium. And this interacts then with the immune system. And this is a good explanation why we have the so-called hygiene hypothesis. Therefore, in countries with a very clean environment, we see much more rheumatic diseases, much more Crohn's disease, and so forth. Australia is a very clean environment, and there are not many countries which have a similar high rate of inflammatory bowel disease. And believe me, every child, everything they stick into their mouth is sterilized, disinfected, clean. And the consequence is that most likely they have a very reduced diversity of the microbiome, and they may lack some beneficial bacteria. But this mucosa-associated microbiome is standardized, it should be relatively stable, and it's also a reservoir for specific bacteria which then go into the luminal. Therefore, this could be the conceptual framework. We have the GI tract, we have the interaction of the microbiome with the immune cells, regulating the immune activation, and playing a role for a lot of conditions nowadays. Functional GI disorder are one group, non-alcoholic fatty disease or liver disease as a whole are relevant. It's believed to play a role for obesity and many other things. The big challenge is if we focus on this mucosa-associated microbiome, how can we characterize this? And in Brisbane, we have developed this little toy here in the right upper panel, which is essentially a biopsy forceps, which is covered by a tube. And the tube is occluded by a plug. And we just inserted through the endoscopy working channel. And we're interested or focus on the small intestinal microbiome, and Aisha will show some more data about this. And this then allows us to take biopsies which are not cross-contaminated by bacteria from the oral cavity or the stomach. Therefore, we put the scope down, we put the biopsy devices through the working channel when we're in the duodenum, we push the plug out, we take the biopsy for sequencing and DNA extraction, but at the end we also take biopsies under anaerobic conditions, which then go straight into the lab under anaerobic condition for culture. Therefore, this is a way not just to take biopsies, and for sequencing, but we also can culture the bacteria from the gut. And here's an example, standard biopsy on the right side and the Brisbane aseptic biopsy. And you see that you get quite different profiles of bacteria, whether you utilize such a device or the normal biopsy forceps. Quick look back at the stool microbiome. This is just one study, N equal 1. A person who measured every day the stool microbiome, and he did traveling, and you can see this heat map shows how much the stool microbiome changed in this single person over time. The blue area, for example, was a time period when he was traveling. Therefore, stool microbiome is probably variable, and unless you monitor very religiously the dietary intake, it might be difficult to interpret. I briefly mentioned our device, and one of the beneficial outcomes is you can look at the density of the bacterial colonization. This is a hotspot for doing breast tests, and this place has done a lot of work which also point towards the limitations of breast tests. Therefore, they're not perfect. The gold standard still is the culture and the quantitating the number of colony-forming bacteria in aspirates. Unfortunately, many countries the pathology labs don't provide the service any longer. They have all very sophisticated automated measurement system for blood-borne infections, but they would not provide us with information on the colony-forming units. Therefore, we thought we could utilize our device, and we do DNA extraction of the human DNA and bacterial DNA, and Ayesha will provide you much more details. But what we saw here is in a very small group, a pilot study, that we have an inverse correlation between the bacterial load ratio of human to bacterial DNA and the overall impairment of quality of life in these patients. Therefore, quality of life is down when patients do have high bacterial loads. And we also could do a nutrient challenge. On the y-axis, the intensity of the symptom response, and on the x-axis, the bacterial load. The more bacteria, the higher the density, the more symptoms you get. And this is then also linked to immune activation. I don't want to go into the details, but if we look at the relative abundance of specific bacteria, we can link this to the immune activation we find in this patient. And this is let's say, the next step when it comes to studying brain-gut interactions. These are some pilot data where we used MRI brain spectroscopy, and we measured specific metabolites in the brain. This is Marcus Gray and Caroline Mountford, who's the director of the TRI, and this is one of their hobby horses they're very keen to do. And what we see in selected cases, there are distinct differences with regard to the molecular profiles which we can demonstrate in the brain. Therefore, this is not functional MRI where you measure changes of the blood flow. These are static changes, how specific metabolites are different in the brain in this kind of patient. This is very much at the beginning. Therefore, pathophysiology with an environmentally factors, stressors, life experiences, antibiotics, GI infection, and diet. And on the other side, the genes, which may regulate sensory function. And then we have the interaction between central processing, control of gut function, and what I did not mention is really metabolic products of bacteria like methane, who profoundly can affect or influence gut function. Therefore, this quick summary: highly prevalent, immune activation is relevant, associated with the microbiome, and the modulation of the immune function via the mucosal microbiome might be quite interesting in the future. And now very quickly to treatment. What are the established treatments? General patient management. You reassure the patient that there's nothing what will kill him. Dietary interventions, very smart, avoid the stuff which you don't tolerate. And then pharmacotherapy. The main drugs are prokinetics, proton pump inhibitors, tricyclic antidepressants, antibiotics, whether the antibiotics are being given because there's belief that the Helicobacter pylori eradication is of any benefit in this condition, or they're now more specifically given in patients with IBS to treat suspected bacterial overgrowth. And then finally, I've listed herbals, and we also use the probiotics. Targets for dietary interventions are really huge. Therefore, I will not go into the details, but there is evidence that the FODMAP diet is evidence-based and can be used. I have to admit that I'm disappointed about FODMAP diet because most patients I see don't respond to FODMAP diet, or had a response and then relapse, or these are patients who find the FODMAP diet completely impossible to adhere to. Therefore, FODMAP diet might be suitable for a small group, but I think it's at the moment really a big wave, but I don't think that long term it will be beneficial. What to do if diet fails? Herbals. In the Western world, herbals are very attractive. When I was a resident, I was approached to help with a clinical trial on a herbal medicine with the name Iberogast. And I had to admit, I never heard about it. And I said, herbals in this kind of condition? I'm coming from academic medicine. It's complete bullshit. I mean, if they want to do studies, we're very happy to help. We piggyback some nice epidemiology, kiss it to death, and finish this. And this is one of these products, STW5, with 9 different plant extracts. And then we did what I think it's a shotgun approach. There are a lot of active drugs, that's peppermint oil, 5-HT4, 5-HT3, and whatever. There are lots of biological active components. And this was then the first study which I designed. And it was a relatively tough study. We had on the y-axis as outcome parameter complete relief of symptoms. And we had 4 treatment arms. One treatment arm were patients who were treated for 8 weeks in total, 4 and 4 weeks with active therapy. Then we had 4 weeks active followed by 4 weeks placebo. Then one group which had 4-week placebo and then 4 weeks of active therapy. And the last group was placebo, 4 weeks followed by 4 weeks placebo. And on the left side are patients who had active followed by active. And more than 40% had complete resolution of symptoms as compared to round about 5% just on placebo. And you can see that if you start with placebo, you have a placebo response, which is not a big surprise because these conditions are cycling. You typically recruit a patient when he has severe symptoms, put into the trial, and then he gets better, but all went down and there's no long-term effect. Overall, the active medication with the ibuprofen, the longer essentially, the better symptom control. And this has been replicated with a number of trials, and I had to completely change my mind. And patients actually prefer this kind of, because it's not chemical, it seems to be natural, and it works. And it's reasonably cheap. What about relapse rates? And this is a study which we then did, funded by the NHMRC. Patients were recruited, randomized, and in this study we had placebo, STW5, proton pump inhibitor plus, or it's a combination of PPI plus STW. And all this was then followed by placebo, and then placebo was discontinued, but the patients still were monitored. And here should be the data. The initial response to PPI and STW5. On the left side, the placebo response, 25%. Here's a patient with STW5, PPI in a combination, and all did better with active therapy compared to placebo. And then we looked at what happens if we discontinue active medication, but we don't tell the patient. We swap it just to placebo, and the data are here. If you swap placebo to placebo, nobody relapses. If you swap STW5 to placebo, you have a very small relapse rate. If you swap a patient who was exposed to PPI to placebo, you have a significant relapse rate. And this has then replicated by other studies. If you give a healthy subject a PPI and you withdraw it, the subject will get symptoms. And this is obviously what happens here. And the benefit, therefore, if you get symptom relief with a herbal medicine, it's fine, you stop it. It's a PPI, it's much more complex, you need to look into what happens. And here then the final step, what happens if we withdraw placebo? Withdrawing of placebo causes relapses in those who responded to placebo, but there's no difference between the different active therapies, which is anticipated. Therefore, truly a PPI will result in a relapse because most likely the gastric hypersecretion is bad. And it's not just STW5. This is a study which we published last year on a combination of peppermint oil and caraway. This also works. Therefore, the spasmolytics, these herbal medicines, can relieve symptoms. What to do if herbals fail? Probiotics. This is a systematic review by Alex Ford, and very clearly the drugs, the probiotics he tested or he analyzed were positive. Therefore, probiotics can be considered evidence-based. Interestingly, I'm aware of a study from India where they tested the probiotic products sold in pharmacies, and interestingly, when they tried to verify that in this preparation was what was supposed to be, in most preparations they were not able to find the bacteria or the bacteria in the concentration that the distributors claimed. The only exception was that if this were products from reputable producers, international pharmaceutical companies who bring them to market, and obviously are more have more stringent quality controls. Prokaryotics is one study which I mentioned before, itopride, and I believe itopride is available in India, significant response, but these were patients who had an overlap of symptoms and were more on the severe side, and clearly all doses were significantly better as compared to placebo, and I think this can be translated to other prokinetics who do have a neuromodulatory effect, who are not just stimulating motilin receptors, for example. Antibiotics, now widely used in the United States for IBS, rifaximin, and it's very clear there is a significant effect, even though the effect is not affecting 80%, but probably 20-30% will get better. TCA, tricyclic antidepressants or antidepressants, I think are the most potent drugs for patients seen in the tertiary sector. Interestingly, this is a study which Nick Talley did, funded by the NIH in the United States. Interestingly, the modern SSRI do not work, but what works are the old dirty tricyclic antidepressants. We typically use doxepin, but if you look at the odds ratio, this is really very powerful. In summary, highly prevalent, they cause substantial morbidity, patients have significant comorbidities, psychiatric comorbidities, inflammation key driver, and future research clearly needs to look at the microbiome and the interaction with the microbiome and the immune system. And I think India is a great place because you will see dramatic changes of the microbiome, which ultimately will translate into diseases which are microbiome related. And there's an opportunity to study this now. And if I could advise, take biopsy samples, store them, and measure the microbiome cheaply when the technologies are available in 3, 5, or 10 years. And I think this was my last slide. Thank you very much for your attention.